Well, hello again to everyone, and thank you for joining us for today's webinar on common pathology coding errors and how to avoid these mistakes that can hurt your billing and reimbursements. My name is Alex Mitchell, and I'm a communications manager at Lighthouse Lab Services who will be serving as your host today. And I'd like to quickly introduce our two expert speakers from Lighthouse today. First, we have Billy Mildenberger, Lighthouse's Director of Audit Services. Billy is an accomplished professional with over 30 years of experience in various facets of revenue management, billing, and auditing. As the Director of Audit Services at Lighthouse, she plays a crucial role in ensuring compliance, accuracy, and efficiency within the revenue cycle. Her expertise extends to the intricate world of pathology and laboratory coding, where she navigates the complexities of medical billing with precision. Billy understands the nuances of coding guidelines, reimbursement policies, and payer requirements, allowing her to optimize revenue streams for healthcare providers. Notably, she holds certifications from the American Academy of Professional Coders, including the Certified Professional Coder and Certified Professional Biller credentials. These certifications underscore her commitment to maintaining the highest standards of professional competence and ethical conduct. And we also have Holly Wolford, our lead RCM and coding specialist. Holly's also a seasoned RCM professional, boasting more than 20 years of experience in this industry. As our lead RCM and coding specialist, she plays a key role in ensuring Lighthouse clients maintain billing compliance while simultaneously working to create an efficient and healthy revenue cycle. Holly also holds certifications from the American Academy of Professional Coders, including the Certified Professional Coder and Certified Outpatient Coder credentials. These underscore her commitment to maintaining the highest standards of professional competence and ethical conduct. So I just want to thank them both for sharing their time with us today and expertise as we dive into this complex subject. Just briefly, I'd like to touch on some housekeeping items. You can reduce your chance of buffering by closing any apps you might have running in the background. So if you're lagging, go ahead and do that. This webinar is being recorded, and it will be sent out to everyone who registered afterwards automatically, so no need to request that. Additionally, the slides are available under the handouts section. If you look next to the chat and Q&A box on the right, handouts is on the far right, and you can go ahead and download those slides there. We are going to do a Q&A, but no need to wait to the end to ask questions. You can go ahead and pop those into the Q&A channel. We'll be reviewing them and publishing them. If we don't get a chance to answer your question today, or if it's not one we can address live on the call, please don't hesitate to follow up with us after the event. And there's also going to be opportunities for you to fill out some forms if you want to connect with us directly for a free consultation. And we also run a few polls during the webinar. They're totally optional, but we do encourage you to participate if you'd like to. I just want to make one more note about our slides today. Some of our coding and documentation examples we share were clipped and redacted from real examples, and they may have a few minor legibility issues in this presentation format. If you're struggling at all to follow any of the examples on screen, I highly encourage you to download the slide deck in the handout section and follow along with the PDF, or reference it later for further note. And quickly, I'd just like to tell you a little bit about Lighthouse and our services. We do provide a number of services to medical laboratories and pathologists, and that's how we're able to offer these events and keep them free. But in short, we're the nation's leading full-service medical laboratory consulting, revenue cycle management, and recruiting firm. If you're looking to fine-tune your billing and collections, we offer the nation's leading RCM consulting and auditing services for labs and pathologists. From charge creation to EOB, our team finds the billing issues that affect your revenue or jeopardize compliance. So in short, we help our clients recover millions of dollars in lost revenue each year due to incorrect coding. So if you have any coding concerns, billing concerns, please, we're offering a free consultation with our team today. We can, touch on some of your pain points and maybe discuss how we can help you. That offer is available next to the handout section as well. You can use that slide out to open the form if you'd like to fill it out later and connect with us. And we'll give you one more opportunity at the end of the call to do that as well. And with that, I'm going to go ahead and turn things over to Billy.
Okay, thanks, Alex. We've provided this webinar to go over some of our most prevalent coding errors in 2024. Something to note, we've been in this space for a long time, auditing AP practices. I know I've been doing it for over a decade, and Holly has as well. So our focus, although on 2024 dates of service, some of these finds that we're identifying today and discussing are common throughout the years. We see the same thing over and over. Several of our common coding errors for 2024 that we're going to touch on today is going to be reviewing IHC stains, special stains, fine needle aspiration, adequacy interpretations, specimen level issues, and then commingled tissues. And today's objective, these slides will offer some detailed reviews of our coding errors and provide some examples of incorrect and correct coding or documentation. Just to let you know, if you basically, if you are having any issues that you would like to reach out and discuss with us, we're more than happy to help review some of those documentation examples. So the first one we're going to discuss, and this is one of our most common errors that we identify throughout our audits, are going to be related to immunohistochemistry stains. Some of the common errors that we identify, some of our clients are billing per block. They're miscounting stains and then billing an incorrect number of stains, or they're billing improper CPT codes based on the results and methodology. So we didn't outline all of the CPT codes in IHC stains just because the common findings are related to 342, 341, and 360, 361 CPTs. As you know, comprehensive documentation is essential for selecting the appropriate CPT for IHC stains. The method, be it manual versus computer assisted, and the results significantly influence the code determination. And additionally, listing each antibody along with the corresponding results supports accurate billing. Remember that all IHC stains are coded per specimen, not per block. And that basically is different from special stains where they want it per block, not per specimen. So we want to definitely point out that IHC stains are going to be performed per specimen. What we want to see with qualitative stains is a positive negative result. They should be reported per specimen using codes such as 342 for the initial single antibody stain on that specimen. And then anything after should be reported as a 88341 for each additional single antibody stain. As far as quantitative or semi-quantitative stains, those you'd want to report as a 88360 with a scoring system from 0 to 4. We typically don't see that very often, or a percentage result, for example, 58%. That would require a 88360 if it is a manual analysis, and then if it's computer assisted, you would want to code that as a 88361. On the next slide, we'll present some examples of IHC stains and then have Holly walk through the details surrounding that stain.
Okay, so this is our IHC coding example. For the example, there was qualitative IHC stains. There was an ER, a GATA3, a CX7, a CX20, a TTF, and a CDX2 that was performed. And then also a quantitative ER was then also done on the same specimen. And this was incorrectly coded as an audit because it was billed as an 88342 and then an 88341 × 5. and an 88360. The ER stain was billed twice, and it cannot be billed twice because, again, the 88341 is for any additional unduplicated IHC stain performed on the same specimen. And because the ER was done as a quantitative result and a qualitative result, you could only report the 88360 for the quantitative result, because again, it's a duplicated stain, and you can't intermix. If a stain was done as a quantitative and a qualitative, you can only report it once. You can't bill both of them.
And we would recommend that you would obviously, use the code as a 88360 or 88361 if you're performing it both quantitatively and qualitatively, because that leads to higher reimbursement.
Right. And the other recommendation I would make, that when you are performing a quantitative IHC stain, to please make sure that if it is manual, that you documented that it was counted manually, or if it was counted computer assisted, that documentation needs support that it was computer assisted.
Yeah, that will ensure that if at any time you're audited, if you provide that report and it doesn't say computer assisted and you're charging at 88361, they'll deny it because the documentation doesn't support the method that you're performing that stain with. So it's very important to document everything, just not only for compliance, but it's going to make the coder's job a lot easier to apply the correct CPT code. Okay, we're ready to move on to special stains. Common errors that we find in special stains is not reporting per block. So it's common that it's documented that the stains performed on each block, but the CPT codes don't correspond with the units, or the CPT code's there, but the units don't relay that they were actually performed on, say, for example, three blocks have a special stain performed and you're only billing one unit, either because you're not aware that they could be reported per block, or usually vice versa, the documentation doesn't support, and so you're not putting that additional unit on the claim. We also find that not documenting what block the special stain was performed on doesn't support those special, or support the multiple units. And so it's not going to look like those stains were applied, and it's not going to meet the documentation requirements for those units. Another thing that I didn't outline on the common errors, and this is a pretty big one, it's common that certain special stains could be reported as a 312 or a 33 or a 313. We find that pretty often within our coding audits, and an example of this is a POSH stain. Depending on what use, if it's a microorganism, it could be coded as a 312. And so that's something to look out for. Make sure you are documenting what that special stain was, the result, and what it was performed for, and then you may be able to bill that for each result, depending on if that's documented. So thorough documentation is crucial for these special stains. The distinction between group 1 and group 2 significantly influences the code selection. Additionally, listing each stain alongside its corresponding result ensures accurate billing. There is a new Medicare LCD that takes effect next month. And so this practice of documentation really is going to be important. Remembering to bill for each unit of each special stain on every single surgical pathology block is going to be crucial, especially if a payer wants to perform a audit on that. You want to make sure that it's bulletproof and it's going to meet that documentation requirement. Again, special stains can be performed per block with clear documentation for each stain that's performed on each block. You'd want to use 312 for group 1 and 313 for group 2, all other stains. We have an example here of a special stain, and Holly will walk through that example.
Okay, so for the first one, for the incorrect documentation, this was reported as an 88313 times 2, but the documentation only supports one elastic stain. It doesn't specify what specimen or block it was performed on. So this one truly should have been coded as just as an 88313 times 1. The correct documentation, which again is a little hard to see, but there was a reticulin stain done, and in parentheses it says that it was on A1, A3, and A4, and then it gave the results of that stain. So this was properly coded and documented as an 88313 times 3.
Another top find that we see is the documentation of fine needle aspirate adequacy interpretation, and it's going to be the add-on code 88177. The common errors that we identify throughout the auditing process are documentation does not support the evaluation episode, or it doesn't support the time necessity for that charge. So for supporting documentation for the 88177, it often presents challenges to groups. There are numerous variations in the documentation for this charge. We see a lot of different formats, and a lot of that might be tied into your LIS. So it's common to find that the provided documentation does not substantiate the billed charges. So they will be billing multiple units for 88177, and there is no way for us to tell that it was a separate evaluation episode because of that separate evaluation episodes not listed under that template, or the time isn't properly documented. And we'll show an example here in a second. The documentation to support that 88177 must include the time or the separate individual evaluation episode for it to be considered a separately billable 88177. It's used on each separate additional evaluation episode after the initial evaluation episode on the same site. So we'll walk through an example of the fine needle aspiration documentation.
Okay, for the incorrect documentation, this was reported as an 88172 times 2 and an 88177 times 7. And it was documented each pass. And because there's not evaluation episode, it's unclear in this documentation if each of those passes were done separately or were they given to the pathologist all at once. So unfortunately, the 88177 for this documentation is not supported and therefore cannot be billed. The correct documentation would be how they have it listed here: evaluation episode 1, evaluation episode 2, evaluation episode 3, evaluation episode 4, evaluation episode 5. So this documentation supports that each pass or each look at these evaluation episodes were done at separate times. So this would be correctly coded as an 88172 for your initial evaluation episode, and then an 88177 times 4 for each additional evaluation episode. Now, the other thing that can be reported, and we did not get an example of that, would be the time. So if we go up to the incorrect documentation, you could simply do like how it has LR first pass, what you could do is you could put at 8:42 and then your findings. And then you can say LR second pass at 8:50. That would be enough documentation to support that those were done at 2 different times. So then that would support an additional evaluation episode. The same thing for the third pass. You could do at 8:56. As long as they are at different times, that would be enough documentation to show that each of these were done at different times and they were each their own separate evaluation episode.
Okay, another issue that we identify throughout our auditing process is specimen level. This is very common. General miscoding of surgical specimens. As you know, properly selecting the correct CPT code for pathology surgical specimens can be challenging. The CPT book doesn't really provide a comprehensive list of all the specimens that we see. And so there are some helpful resources available. I know there's some rapid finders out there on the web. We developed at Lighthouse a comprehensive list of specimens that provide a crosswalk to the appropriate CPT code that we will be able to share with you if you reach out. But it's very comprehensive. It provides very specific detail for the surgical specimen that may be presented on the surgical report, and it provides the appropriate CPT on that crosswalk. Now, we do know that a lot of clients have coding specifics, and they may be more prone to down coding something if they're not sure. This really is aligned with best practice for pathology as a whole. So if you do have specific guidelines and policies in place, obviously you would want to write those up in a handbook for yourself and make sure that all of your pathologists are aware of that policy. We'll walk through one example of a specimen level that has been coded incorrectly and what the correct CPT code should be on the next slide here.
Okay, the one we see a lot for specimen level example is when it comes to breast tissue. With breast tissue, there are a lot of codes out there for breast biopsies, lumpectomies, and so forth. So for the incorrect code, this was a breast tissue biopsy, and this was reported as an 88307. But in order to code for an 88307, there has to be documentation of margin review. There is no documentation of any margin being reviewed. So this was incorrectly coded as an 88307 when it should have been coded as a 305. Margins can be inked, but they also then in either your microscopic or your final diagnosis has to mention something about those margins were reviewed in order to support that 88307 charge. So for the correct code for a breast biopsy, again, we have two biopsies and masses. Again, there were some inked, but the documentation doesn't support any margin review. So this was correctly coded as an 88305 times 2. The other one that we see for specimen level example of incorrect coding is skin. It turns out that it's a skin biopsy, but then after the pathology reviews it, it turns out to be a lipoma. And we still see that those are still being coded as 88305s because they see it as a skin biopsy. But because only a lipoma was found, it would have to then be converted to an 88304.
And then we have commingled tissues. So common errors that we identify is just the incorrect coding of commingled tissues. These are when multiple specimens are combined into a single container. Determining how each code individually can be coded is complex. Specimens are often bundled or unbundled based on the type of specimen received. There's a lot of different examples of this. We've included the most common that we find in our audits, but we can also speak about one other specimen that's often challenging for pathologists. On the next slide, we'll walk through an example of a commingled tissue example.
The one thing that we do see a lot is the uterus with fallopian tubes and ovaries. The incorrect code on the top is a left fallopian tube and ovary, and then the uterus is specimen 5. For an ovary is usually bundled with a uterus specimen, even if it's submitted in separate containers. It's usually bundled unless clinical record suggests or suspicion of significant pathology might be found in that ovary, or if an intraoperative consult, like a frozen section or just the OR consult, was performed on that ovary, or if significant pathology was found in that ovary. And in the correct code example, there's none of those three. There was no intraoperative consult done on that specimen 4. There was no clinical history to suggest significant pathology would be found, and there was no significant pathology found. Benign epithelial cyst of an ovary is not considered significant pathology, so that specimen should have been bundled with the uterus and not separately billed. For the correct code selection, this one where the ovaries were in the same container, but because of the serous cyst adenoma found in both the left and the right ovary, that is significant pathology. So again, even if the ovaries are in the same container as the uterus, if significant pathology is found, or if an intraoperative consult is done on one of those ovaries, one or both of ovaries, or if clinical history suggests that significant pathology might be found, those ovaries are still separately billable. That's why this case would be an 88307 times 3, because of those ovaries finding the serous cyst adenoma. Another example of commingled tissue is a Whipple procedure. A Whipple procedure is usually the pancreas. The pancreas is the main specimen, but a lot of times that surgeon will take out more than the pancreas. They could take out some common specimens that I've seen with Whipples are the spleen, a significant portion of the stomach, and sometimes a significant portion of the duodenum. So with the spleen, no matter what, the spleen is always separately billable if it's in with the Whipple procedure, no matter what. The duodenum or the ampulla levata, if it's just a simple margin, which is a tiny, tiny piece that came with the pancreas, it's not separately billable. But if you get a significant portion or a significant length to where it's more of a resection, that duodenum would be separately billable. And then the charge would depend on what the pathologist's work was. Was it a resection other than tumor, which would be a 7, or is it a resection for, is the small intestine resection for tumor, that would be a 09? That would depend on the documentation. The same thing for the stomach. If it's just a snippet of gastric tissue that maybe got just attached to the pancreas, it's not separately billable. But if it's a significant portion that's equivalent to a subtotal resection, then it is separately billable. And again, the charge for that is going to depend on what it's being taken out for. Is it a subtotal total resection other than for tumor? Then that would make it an 88307. If it's the stomach subtotal total resection for a tumor, then that would make it an 88309. So that's another example of commingled tissue that it might come all in together in the same container, but there are chances that it's separately billable.
Now we'll discuss some of the documentation requirements that may impact reimbursement. As you know, detailed documentation is a foundation for the proper CPT code. The documentation must clearly support the medical necessity for the services provided. We've identified many times that the MUE and CCI edits result in upfront denials, and a lot of times those appeals require the inclusion of the final report to ensure the appeal be overturned. Unfortunately, many times that documentation isn't enough to overturn the original denial, and it leads to unsuccessful appeals and sometimes payment recoupment. So it's really important to review the documentation that you have on your final report. Make sure that everything is outlined, resulted, reported, everything's clear. You're very confident that that documentation will support not only the medical necessity, but the result of that procedure or specimen, stain, etc. Detailed documentation will become crucial in the upcoming months, especially if you're in the 2 MACs, Palmetto and WPS. They have recently finalized their new LCD regarding the documentation requirements for special stains and IHC stains. So I don't imagine that it's going to be too far in the distance here that they're going to be starting to request documentation to support those special stains, IHC stains, and they're going to be denying them up front. Providers in the Palmetto and WPS MACs are encouraging to review the new LCDs to ensure their clients are encouraged to review the new LCDs to ensure that your documentation will meet those required conditions. You want to do that before that takes effect. That way, if you do require submitting those final reports, you're pretty confident that they will meet the needs and they will be paid appropriately. Those LCDs do go into effect July 14th, 2024, and we've attached each LCD. You should be able to link right to it and review the clear documentation. It's pretty similar. They might have a couple different nuances between the two. But that being said, if these MACs are going to go and make these effective July 14th, I wouldn't be surprised if the other MACs follow suit, as well as some commercial payers. So if it's successful, be aware that there might be more coming, and commercial plans might be changing their requirements as well.
And just a quick note for anyone interested in following those links, they're not live on screen right now, but if you download the slide deck, they are live in the PDF.
Okay, so common mistakes and considerations when billing molecular and genetic testing. We also perform a lot of lab audits, and throughout the years, these tests have significantly advanced. There's some complexities here billing these different genetic and molecular tests. And so we wanted to outline some key considerations and kind of mistakes that we identify. A lot of times you can see the use of incorrect or outdated CPT codes. You want to make sure that you're going through and updating those changes as they happen. Using unlisted codes when a specific code exists, you want to make sure that you have the correct CPT code selected and billed for your testing. And then failing to support the charge by not documenting the medical necessity or test result on that final result is very, very important, because a lot of times payers do want you to submit the final results for support if they deny those charges. Understanding policy and coverage limitations. It's really important to know the national coverage determination and local coverage determinations, as well as the commercial payer policies. They have a lot of different policies for these types of testing. This will allow you to outline reimbursement policies and have a good understanding of how that payment will be affected. And then it's super important to know your payer mix and research whether you participate with the plans that represent your target population. I know that we've had a couple of clients that Medicaid is their payer population, and it was deemed that, you know, they went ahead and submitted for a unique CPT code, and Medicaid doesn't accept that CPT code. So it's really important to know your payer mix and identify payers that require pre-authorization, because you'll have to really make sure to have a good, robust pre-auth policy in place and try to get that up front to make sure that those tests are paid from those payers. So staying updated on payer guidelines is crucial with molecular and genetic testing, and making sure that you really understand those coverage limitations. So as this wraps up, we do want to touch base on 7 OIG recommendations to ensure compliance. They wrote something back in, I believe it was 2023, And these are their top 7 recommendations. So you want to ensure that you have written policies and procedures in place. You have compliance leadership and oversight, training and education, effective lines of communication with the compliance office and disclosure program, enforcing standards, consequences, and incentives, risk assessment, that includes auditing and monitoring, either internal or external. Making that a part of your compliance plan is super important. A lot of our clients make our audits part of their compliance plan, and so we're handling that piece of that compliance plan for them. And then responding to detected offenses and developing corrective action initiatives. These are all 7 OIG recommendations that we really advise clients to put into place to make sure their compliance is up to date.
Well, thank you, Billy and Holly. That was very informative and certainly diving into issues that I won't even pretend to have a full grasp on, but I think our audience was really glad to get some of those insights today. Really quick, before we dive into Q&A here, I just want to invite everyone to join us for our next webinar. Every year, we do a wage and morale survey of medical laboratory professionals, trying to boost wages and staffing situations within the industry. We also explore responses from lab directors and pathologists. So if you're interested in joining us for that and getting that full report, please join us. That'll be on July 31st at noon next month. And you can use that form to sign up there, or we'll have several pushes going out to everyone over the next month. So you'll have opportunities to do so. And we're going to go ahead and take a few questions here. Again, if there's anything that we're not able to speak to on the call today, I highly encourage you to follow up with us either by using that email address or the offer form that will be pushed out again following the Q&A section. You can also still access that under the handouts and offers tab. But we're going to go ahead and touch on a few questions while we have some extra time here. We have one question about Darlene asks, I know that 88360 can be used as a professional charge. Can it also be used as a technical charge?
Can you repeat that one more time, Alex?
Absolutely. And again, if there's anything that we're not 100% certain on the call here today, we can follow up on it later and we'll get your question answered. But Darlene was asking that she knows 88360 can be used as a professional charge. She was wondering if it could also be used as a technical charge.
It can, yes.
Okay. Thank you, Billy. Tabitha was looking for some clarification on the 312, 313 new LCDs. Which locations are being impacted by those LCDs?
Let me look. I should have that available. So for Palomento GBA, that covers Alabama, Georgia, North Carolina, South Carolina, Tennessee, Virginia, and West Virginia. And WPS covers Indiana, Iowa, Kansas, Michigan, Missouri, and Nebraska.
Thank you, Billy. We have another question here about, is it difficult to find compatible ICDs for surgical specimen CPT codes? Do we have any knowledge there?
Does she mean ICD, like the ICD-10 for diagnosis coding?
Yeah.
If that's what she means.
Yeah.
There is no compatible ICD-10s for surgical specimens. For diagnosis coding for pathology, you want to code based on the pathologist's final findings. So it could be different for every specimen that's out there. For example, a breast biopsy, it could just be a breast cyst that they took out over the breast biopsy, or it could be cancer. So it's for pathology ICD-10 coding, it's going to depend on what the surgeon, or what the pathologist finds after doing the microscopic description and what he deems as a diagnosis for that specimen. If everything comes out fine and there are no findings, then you would go back to the clinical history and use the clinical history as to why the surgery was taken. Like you can get a stomach biopsy, maybe because they have, you know, acute or chronic abdominal pain, but they're not finding anything in that biopsy. So then you would go and just do that chronic abdominal pain.
Thank you, Holly. Another one here. If a breast biopsy, in breast biopsy, if the right and left side biopsy is done, how would you code that? Should you code it with modifiers?
I would say no, because more than likely it's going to be two different specimens, two different cassettes. So right could be in cassette A or specimen A, the left is going to be specimen B. Because you have two separate specimens, there's no, I'm aware of no modifiers would be needed to code those.
I'd agree.
Thank you both. This one I don't have a full understanding on, but in cases of Whipples, just to understand this, just to clarify here, are the stomach and the duodenum not always separately payable?
Not always, but for the most part they are, because usually the Whipples that I've seen, there is a significant portion of the duodenum and the stomach separated out, and a lot of times there's actually findings in that stomach and the duodenum. I've seen it for a Whipple that it could just be the pancreas, the stomach, and a spleen. I rarely see that the stomach is just a mere margin. It's usually a significant resection of that stomach. So yes, there is a possibility, but it's rare. What I've seen, it's rare.
A great answer, and thanks for cleaning up my mispronunciations there, Holly. I appreciate that. One more here. If two specimens were taken during a procedure and sent to two different labs, how would you bill that 305 when there is another lab that's also billing it? Would there be a 59 modifier or a more specific modifier for that example?
That's gonna depend on it's the same specimen sent to two different labs.
Two specimens taken during a oh, that one just disappeared on me. I'm not sure where it went. Okay, so if two specimens were taken during a procedure and then sent to two different labs, how would that 305 be billed when that other lab is also billing it?
I think we'd have to see an example of that.
Yeah.
That's hard to say.
Okay.
Yeah.
Yeah, definitely. Please, Jennifer, feel free to follow up with us on that one. A little more specifics might help us direct you a little better, and we don't want to provide any bad information on the call today. And we're going to go ahead and Holly and Billy have been taking a marathon of quick questions here. So we're going to go ahead and do one more. And so please, I'll push that form again after this. Follow up with us if we have not had a chance to touch on your question. But a final one here from Debbie. Are all commercial payers now requiring the G code for prostate biopsies, G0416, or are they still accepting 305 times X units?
It's really going to depend on the payer. I know UHC and Cigna have adopted it. I don't think every payer has adopted that yet. So you're going to have to reach out if you're unsure, but a majority of the major health plans do require the G0416.
Perfect. And I know there were a few I didn't address, maybe just a little too specific, like I said, to touch on the call today. So please, if you have more questions, go ahead, use this form or that email address on the screen. You could follow up with us. We could schedule a free consultation in the coming weeks, sit down and discuss your exact needs, your exact questions, and see if there may be some additional help we can provide beyond just answering that. But again, I'd like to thank both Billy and Holly immensely today for sharing their expertise. These are complicated issues, and we certainly appreciate that they were willing to hop on and join us today. So thank you again, Billy and Holly.
Thank you, Alex.
Thank you.
All right. Bye-bye, everyone.